The first patient I met from Ireland was Tommy, and that was almost 20 years ago. And then I recognized many faces here in the auditorium. So I think many of you know me, and I have spent more than 30 years in the medical treatment of neuroendocrine tumors, and a lot of things have happened. We have many more options now, but it's also coming more tricky to decide which sequence. So it's a nice problem, we can say. Mark instructed me I shouldn't bring any slides. I don't have an iPad because I gave them to my grandchildren, so I have small notes, paper notes, just commenting a little bit about some news and also how we evaluate patients, because that has also been developed. We do want to know where the primary tumor is, because that can affect the therapeutic choice also in patients with metastatic disease. So that's important. And you can get that from imaging, and the fact that you're going to get a gallium PET examination may make it possible to find small lesions. We have problems sometimes to find the primary tumor because treatment differs. And then we also need to know the stage. How spread is the disease? Are the lesions in the liver, elsewhere? That also affects the treatment, the involvement in the liver, what should we do? Another thing very important, and that was introduced in the 90s, is the proliferation rate, the Ki-67. These tumors are slowly growing. Very small percentage of cells are dividing, maybe 2%, or it could be up to 20%, and that will also affect our choice of treatment. So we check that in every patient nowadays. And then, does the patient have hormonal symptoms? That's another factor that we consider. And then also what we call performance status. How is the well-being of the patient? What is the age in a patient older than 65, which I am? The kiddies may be more sensitive to chemo, for instance, so you may consider that too. So this is a background. And then I would like to mention a few important developments recently. And I would like to mention a large trial performed with lanreotide, the clarinet trial published in 2014. We knew many years ago, already from the 80s, that you should give somatostatin analogs to patients with hormonal symptoms. But what about those patients who don't? Should we give them sandostatin LAR or somatulin? And that study, Clarinet, showed that that should be done. There was a selection of patients who received the treatment. It was a randomized trial comparing lanreotide in one arm to placebo, no active drug. And the patient should be Optoscan positive and have relatively slowly growing tumors, looking at Ki-67. But it was shown that patients who received the drug had a longer time to progression. So that is now clear. If we can, in low proliferative tumors, start with somatostatin analogs also in pancreatic tumors, for instance. That is very important. And then, what about PRT? Many of you have come to Uppsala for PRT, and Dermot mentioned the NETO study. I think that is very important. As you know, we are doing our own clinical trial in Uppsala, where we try to use a different protocol from the Rotterdam protocol. They were first in business, and they have a standard of giving 4 cycles of lutetium. Now, in Uppsala, as many of you have noticed when you have been there, we do very careful dosimetry. We measure the amount of radioactivity that goes into sensitive organs like the kidney and bone marrow, so that they don't get too much radioactivity. And then we try to increase the number of cycles. Instead of 4, we give more cycles to give more radioactive treatment to the tumors. Now, we have treated the patients in a clinical trial, and we did a sort of evaluation in 2013, looking at more than 200 patients, and we had similar response rates as the Rotterdam group, but there were fewer patients who had progression 20% of patients in the Rotterdam results had progression during treatment, only 4% in our trial. Most of patients had responses, 30%, or stable disease. But we are now collecting data, and it's a big job to collect data, follow up from patients in other countries. So we're working on that. And you mentioned the NETA study, so it's very established. Another type of treatment that I would like to mention, it was introduced by myself in 1999 in a very ill young man who had received several lines of treatment at a primary tumor in the thymus. So there were no options left. I tested to give the patient temozolomide, and he responded. And this was the sort of an initiation of the study. We gave this drug to other patients who had had several lines of treatment, and with temozolomide as the single agent, we saw responses or stabilization. Temozolomide, by the way, is an oral chemotherapeutic drug. And we also checked in a recent study what about patients who have the primary in the lung, not only pancreas and thymus, and they also respond, at least with stabilization. And this drug, temozolomide, is then now being tested in many countries. In the US, there's a publication giving temozolomide plus another chemotherapeutic agent, capecitabine, responses as first-line treatment, 70% of patients with pancreatic tumors. But that was a retrospective study looking backwards, so it has to be validated by others. So that was temozolomide. And then, of course, the introduction of Everolimus was a big step forward. The results of the largest randomized trial was published in New England Journal in 2011, comparing Everolimus, which is a molecular targeted drug, to placebo. And it showed that there was a difference between the active arm and the placebo arm. This was in pancreatic tumors. The size of the tumor didn't shrink so much, but they had a prolonged period with stable disease. There are side effects that we have to learn. One of the side effects is that patients develop high blood glucose, hyperglycemia, and that has turned out to be very useful in patients who have tumors that produce too much insulin, so that they have hypoglycemia, low blood glucose. We have had 2 patients who have been stable on this drug for 3 years on Everolimus, and even not required the full dose to be stable. So it's a very nice also new treatment. So we have many options now, especially in pancreatic neuroendocrine tumors. Still, if we look at the ENETS guidelines that Dermot was talking about, for pancreatic tumors, grade 2, streptozotocin is considered to be first line, but you could also consider temozolomide now, and I know in the US they have going more and much over to temozolomide. So we have a nice problem, as I said in the beginning. We have many options. And how do we sequence them? I think learning from the Clarinet study, we could feel it more safe to start out with somatostatin analogs also in pancreatic tumors. We do that in carcinoids, small intestinal tumors, with a relatively low proliferation rate. Side effects are few, and the long-term side effects are also very few. But then, when we have come to pancreatic tumors, right now the ENETS is performing a study to see whether we should give streptozotocin plus 5-FU first or Everolimus. That is going to be interesting to see. We are participating in that study. It's very important. And then, of course, where does PRT come in? I must say, as it is now, for patients with small intestinal neuroendocrine tumors, they have a low proliferation rate, and they don't respond so well to chemo. So we give them somatostatin analogs first, maybe interferon, but then PRT comes in, and the NETA study certainly supports that. But for the pancreatic primaries, we do have to think which order we should give the treatment, but that is a pleasant problem. Okay. So by that I would like to stop and say thank you for inviting me here.